Today, it's my pleasure to introduce Dr. Neha Pagidipati. Neha is a fourth-year fellow in the Duke General Cardiology program, and she's currently the Chief DCRI Research Fellow. She did her previous medical training at Harvard Medical School and Brigham and Women's Hospital in Boston. Her primary clinical and research interest is the prevention of heart disease, particularly in those with metabolic disease. And she's particularly interested in weight and lipid management and going to be talking today on metabolic diseases. Thank you, Neha.
Thanks very much. I think this is on now. I'm going to get the clicker. Thank you guys for coming. I know almost all of you. Those who I don't know, hi, I'm Neha. It's nice to meet you. So late yesterday afternoon, I went to Hillary because I had this plan to talk about obesity and cholesterol. But then I realized that was more targeted towards like what patients would need to know as opposed to potentially what somebody who wanted to learn about the clinical aspect would need to know. So I asked Hillary what would be useful, and she said anything. She's really nice. And I went to Tony, and he was like anything because he's really nice also. So I thought that what we would end up talking about is something a little bit different and a little more clinically oriented. And if that's useful, generate energy. We'll get and stuff that are also considered metabolic diseases. I'm not going to talk about that. I know nothing about that. I'm going to talk about the larger diseases that adults tend to get, but also children are getting nowadays as well, including obesity, metabolic syndrome, and diabetes mellitus. So why is a cardiologist talking about metabolic disease? Because this is usually left for either pediatricians or endocrinologists, and that's because I left out the most important part of the term metabolic disease, which is cardiometabolic disease, and that is a relatively new term that some people will say is made up, but it's not. And it's kind of an acknowledgement of the fact that really what metabolic disease doesn't exist in a vacuum. It exists in a human being who has other stuff going on. And what we actually find is a clustering of these interrelated factors that promote atherosclerosis in blood vessels and type 2 diabetes. So again, all of this is very interrelated, and the more that we understand and address that, the better we'll be at taking care of patients. So endocrinologists need to know something about cardiology, and cardiologists need to know something about endocrinology. So within metabolic disease, I thought I'd focus specifically on diabetes because I looked through the other topics and I didn't see that was something that anybody else was particularly addressing. Again, if you're really familiar with this already, please let me know. I can talk about the other stuff. I can talk about prediabetes, metabolic syndrome, obesity, and that kind of thing as well. But the brief outline I thought we'd go through is it's bad, and I'll give you some reasons for why it's bad. What exactly is it? What is exactly happening in the body? What are the different types? What do patients feel? How is it diagnosed? How is it treated? And then you're going to have to vote for me versus somebody else in a diabetes off, just like a diabetes face-off thing. You can tell me who's explained it to you better. Okay. So why should we care about diabetes? It's incredibly common, and I'm going to show you how common it is, and it leads to badness in blood vessels, and that's the primary thing. What do people with diabetes die of? Are they dying of diabetes itself, like very high sugars or very low sugars? No, they're dying of heart attacks and strokes, right? And so this leads to badness. When we'll get to it, not only kills you, but it also makes you feel bad for the time that you're alive, and so it leads to a lot of different issues. This is getting at how common it is, and the maps on the left in each of the panels are of obesity, and the maps on the right are of diabetes, and these are from the CDC. You see these all the time, or at least I do, and basically red is bad, and things are just getting redder and redder and redder. And so the whole population is moving towards greater obesity and greater diabetes, and this is the case not just for the US. I'd like to point out that this is the case for the entire world, especially in developing countries. The rate of growth of these diseases is even higher. So right now in the US, the prevalence of obesity in men is about 35%, and the prevalence of obesity in women is about 40%. And the prevalence, and then here is, Duke is different, we're special, North Carolina is special, and diabetes, the prevalence in the adult US population is somewhere between 12 and 14% currently. Okay, so that's where we are. But again, things are rising rapidly. So why is it bad? And the way that clinicians will often think about the consequences of diabetes or the complications of diabetes, we will often break it down into two buckets: macrovascular complications and microvascular complications. And one theme we'll get at multiple times throughout this talk is that all of this is on a spectrum. There is no, the definitions that we have are arbitrary to a large degree, and all of the things that I'm going to talk about are along a spectrum of metabolic disease. And so that's the case with complications as well. But for ease of use, we generally classify things as macrovascular and microvascular disease. Macrovascular disease is what you expect. The large blood vessels in your body are affected by diabetes because there is an increased rate of atherosclerosis, which is the laying down of plaque that you can see there. And when that happens, you get ischemic heart disease, heart attacks. You get peripheral vascular disease, which can lead to all sorts of badness like amputations. And then you can get cerebrovascular disease, which can lead to stroke. And those are the most those are the largest causes of mortality and morbidity. Microvascular disease refers to the fact that, the blood vessels in the body are like trees, right? You've got the aorta, which is the big tree trunk, and then things kind of branch off from there and get smaller and smaller. Well, when you get to the smaller vessels, those are also affected by diabetes. You also get problems with the endothelium there, and the blood vessels no longer function like they should. And then you can get problems in your eyes, which is called diabetic retinopathy and can lead to blindness, so significant morbidity there. You get problems in your kidneys, and this is a picture actually of the glomeruli, which are the kind of the cells basically within the kidneys, and you get something called diabetic nephrosclerosis. And so it leads to nephropathy. That's the most common reason why people have end-stage kidney disease and need to go on dialysis. Diabetes and hypertension. So leads to dialysis, that's bad. And then you get neuropathy. So what happens is the blood vessels around your nerves, all of your nerves have blood vessels that allow them to function. The blood vessels around your nerves are also diseased, and then your nerves don't function like they should, especially in your distal extremities. And so you start not being able to feel your toes. You start not being able to feel your feet. What do you think happens when you can't feel your feet? Did somebody just say they fall off? Oh, I thought like they fall off. Well, eventually they do fall off because they're taken off. Anyway, yes. So you fall and you injure your feet, and you don't realize that you've injured your feet. And so you start to get ulcers and things on your feet, in addition to the fact that you don't have good blood flow to begin with because all of your blood vessels aren't working well. And if you don't have good blood flow, you're not going to heal the wound that you've created. So now you're more likely to create a wound, less likely to heal that wound, and it's just sitting out there. And as it is, if you're diabetic, you're prone to infection. So now it's going to get infected, and then it does come off. But we usually take it off rather than letting it fall off. Okay, so that's amputations and stuff. So that's bad also. So I'm painting a really horrible picture here of diabetes. But don't worry, if you have diabetes, it's fine. We can treat you. Okay. So what exactly is diabetes mellitus? Does anybody know what diabetes mellitus actually means? What do the words diabetes mellitus mean? Told y'all I was going to make it interactive. Huh? I heard something. In Greek, for Hillary, it's just because I know. In Greek, diabetes means siphon, and mellitus means sweet or honey. So the idea was, I don't know, I guess they knew about this back in ancient Greece. I don't know how many people had diabetes back then, but the siphon part is the fact that when you have uncontrolled diabetes, you pee a ton because you're peeing out sugar. And that's where the sweet or the honey comes from. So it's like a siphon. You're just peeing out a lot of your fluid, and it's sweet. So basically what diabetes mellitus is, to kind of keep it simple for folk like me, cardiologists like me, we just do like plumbing and electricity. We're not so fancy with the hormones. So blood sugar levels are high. And why is that? Well, insulin is a hormone that moves sugar into the cells. And either you don't have enough insulin or your body's not responding to insulin the way it should, and that's what gives you diabetes. Now, again, getting back to the theme of artificial boundaries, we tend to break down diabetes into type 1 and type 2. Are those totally distinct entities? No, they're not. So there can be really young folks who we typically think of would have type 1 diabetes, but they actually have type 2. There can be older folks, 20s and 30s, who are actually developing type 1 diabetes that you didn't expect. And there's like a whole range in between. So it's a spectrum. But just to simplify things, because we hear the terms type 1 and type 2 diabetes all the time, in type 1 diabetes, the issue is your body makes little to no insulin. Okay, so insulin is made in the pancreas, right? Which is this little thing that hangs out here. It looks like it's actually like a yellow piece of fatty looking thing that's kind of like nestled between the liver and the duodenum. And the pancreas is made up of different kind of groupings of cells called islets of Langerhans. And within the islets, they have different types of cells. They have alpha and delta and all these other things. I don't even know what they do. But the beta cell is the one that secretes insulin. So that's where the insulin in your body comes from. It comes from the beta cell in the pancreas, okay? When you have type 1 diabetes, your own immune system is destroying your beta cells, most commonly. Now, there are some forms of type 1 diabetes where it's not clear that it's the autoimmune and we don't really know what's going on. It's all a question. But the vast majority of people with type 1 diabetes have autoimmune destruction of their beta cells. And so if their beta cells are getting destroyed, they're not making insulin. Now, just to kind of keep things in perspective, people with type 1 diabetes are about 5 to 10% of all people with diabetes. So the vast majority of people with diabetes have type 2. But 5 to 10% of people have type 1 diabetes, of the diabetics. And so here you can see you have autoimmune destruction of the beta cells, and so you're not creating insulin. And so what happens is, if you start at the bottom here, you see the pancreas, it's not creating insulin like it should be, and so you have a lot of glucose in your blood, a lot of sugar, glucose in your blood, because the insulin is not telling it to come into the cells. And when that happens, the muscle is unable to use it because the insulin is not telling it to come into the muscle, and so you start to have breakdown of other things. It wants to use the sugar, but the sugar is not there, so it starts to use protein and it starts to use fat. But it's not meant to use protein and fat in large quantities. It's meant to use sugar. So when it starts to break down those other compounds, it starts to create acids called keto acids. Okay? And so one of the things that I just wanted to mention, even though it's not all that common, you've probably heard of something called diabetic ketoacidosis, because that's a very severe complication that usually occurs mostly in people with type 1 diabetes, rarely occurs in type 2 diabetes. And what that is, now this is one of these things that when you're studying for the step 1 boards or the step 2 boards, they have all these like drawings that help you remember things, and I remember these actually help me. So diabetic ketoacidosis is something happens over the course of hours, and basically what happens is they've either, usually because they've had a viral illness or some GI illness or something like that, something has triggered the event and they are not producing enough insulin, and suddenly their muscles are needing that sugar and they're not getting it, and they're using more fat, and then they're generating these acids, which are bad for, it makes your blood acidic, and that's bad for all the other organs. And so your breath starts to smell fruity, like juicy fruit gum. If you ever smelled juicy fruit gum, your breath can start to smell like that. And then it can cause all sorts of other badness, and it can kill you. So it's very severe. And if somebody actually has diabetic ketoacidosis, they can get to the point that they get comatose and that they die. They go into the intensive care unit. They do not stay on the floor in the hospital. They go into the intensive care unit. They get an arterial line put into them because they get blood drawn every hour to 2 hours. And in the beginning, it could be every 15 minutes. Because you have to be really carefully titrating their insulin, which they have none of. You have to be giving them a ton of fluid because they've been peeing out, right? They're incredibly dehydrated. And they actually have a lot of electrolyte abnormalities as well. Their potassium is off and everything. And if you don't do it right, if you overcorrect, you do it too quickly, you do it too slowly, you can kill them. And so it is a very serious thing where people go immediately to the intensive care unit. Okay, so that's diabetic ketoacidosis. Type 2 diabetes. In this situation, your body is able to make insulin. You're not having destruction, at least initially, you're not having destruction of your beta cells, but your body doesn't respond to insulin, and eventually over time, if your body's not responding to insulin, you actually start to destroy your beta cells as well. Not in the same mechanism, and it's not entirely understood how, but you start to not make enough insulin as well. So your body's not responding to the insulin, and you're not making enough, and you can have one or the other or both of those things going on. And so your pancreas is secreting enough insulin, especially in the beginning, but your muscle is unable to process that because there's not enough, it's unable to process or kind of use that insulin. And basically what ends up happening, you've got receptors on your cells, and there's signal transduction that goes all the way. I don't know if you remember this from college, if you took pre-med classes. And that stuff, for various reasons, isn't working. So even though the insulin might be there, it's not doing what it's supposed to be doing, and your muscles aren't responding in the proper way. And so because of that, you still have a lot of sugar in your bloodstream. So what causes that, right? That's different. The first time it was autoimmune. And in general, for autoimmune stuff, you have somebody who's maybe genetically susceptible, but there's some trigger. There's something in the environment. We don't fully understand what it is. There's a lot of theories. that might trigger your immune system to kind of go off. That's in type 1 diabetes. Type 2 diabetes, as opposed to type 1, very clearly has a genetic component. Okay, so type 2 diabetes runs in families. But it's not just a genetic issue. For some people it is, they can have autosomal dominant. But it's also a combination of the fact that you're predisposed, you have it in your family, plus you're obese and you don't exercise. Those things together will very clearly lead to type 2 diabetes. So that, to me, I remember when I was in med school, I thought type 1 diabetes, kids get it, that must be genetic. And so to me, this was counterintuitive. It's not. Type 1 diabetes is much less kind of genetic in nature, and the etiology is much less genetic than type 2 diabetes. So generally what happens is you'll be obese, then you've got other stuff happening, but mainly you're not moving around and you've got genetic susceptibility, and so you'll start to develop insulin resistance where your muscles will start to not be responding to the insulin as they should. And as that happens, then you develop kind of the metabolic syndrome, pre-diabetes. It's a spectrum and you're inching your way towards diabetes. And then you get to diabetes, and then of course you get to like the red hexagon of death, but it's not also always so dire. But okay, so symptoms. So I wanted to show you guys, I don't know how many people are familiar with diabetes, so I thought I would just show a couple videos. So this is an example. This could be like any patient I see on any day, okay? She's talking about her symptoms.
Pressure, it runs in the family.
Seth, can you help me with volume?
High blood pressure and eventually led to heart disease. My mother, she's a diabetic. How it started with me is I had a lot of frequent, urination. And I couldn't figure out what was going on, and I was thirsty all the time. Like it was ridiculous how much I was drinking, and it was taking a big toll on me. So I went to the doctor, and immediately she checked my blood sugar, and it was 228. And she said, okay, so you're diabetic. Then it kind of hit me. This is something serious, especially since it runs in the family. This is bigger than you just sitting down and eating a piece of cake. That piece of cake leads to something.
What are some things that
every single yes, so the piece of cake leads to something. I love how the doctor was like, okay, you're diabetic. Like, we can do better than that, but usually we're nicer. Oh, no, I started over. Sorry. Thanks, I can do that. Thanks. Okay, so that gives you a sense. So, but most commonly, people have no symptoms. People have no idea. So the way that diabetes is picked up most commonly is that there's a doctor who's looking for it. And so we'll check various things, and I'll go over how we diagnose it. But most commonly, people don't feel anything, which is part of the danger of diabetes, right? You don't feel it, you're not thinking about it, and you go on and you eat that cake, or you do whatever, and it kind of progresses until it's too late in some ways, or until things have progressed a great deal. But when people do have symptoms, they're like Yvette said, frequent urination, incredibly thirsty, can have blurry vision. Okay. So how do we diagnose type 2 diabetes? And I don't know how many of you are kind of, I'm sure everybody, when you're doing any kind of analysis on anything, at some point you're adjusting for diabetes or looking for diabetes or controlling for it in somehow. And so you're using various ways to diagnose diabetes, but this is clinically how we diagnose diabetes. Okay, so if you have symptoms, so we kind of bucket people. If you've noticed, we like to bucket things in clinical medicine. Everything has to be kind of binary or in categories for us to understand it and remember it. Otherwise, we don't like continuous variables like you guys. So if you have symptoms, this is the last row here, then even just a random glucose, any given time, if we check a sugar in you from your finger, we prick you, and your sugar is greater than 200, you're considered to have diabetes. And this is the classification by the American Diabetes Association. There are others, but this is a well-accepted one. So if you have symptoms and your sugar is greater than 200 at any moment, you're considered to have diabetes. Vast majority of people, like I said, though, don't have symptoms. And so there are three other generally accepted ways of diagnosing somebody with diabetes. One is you have a hemoglobin A1C of at least 6.5%, and I'll go over in a second what that means. You could have a fasting glucose of at least 126. So first thing in the morning, you haven't eaten or had anything to drink, and we check a sugar, and it's still high, above 126. Or you can have a 2-hour glucose. And this is not something we actually do very commonly in clinical practice, but I'm going to review what it is, because at least some of you who are working with me now are seeing a lot of these GTTs and OTTs, and what does that mean? We'll go through that. So hemoglobin A1C, just so you know what this actually means. So we know that hemoglobin is a protein in red blood cells, right? So you have a ton of red blood cells that carry your oxygen around to all of your tissues. The hemoglobin is a protein in your red blood cells. And hemoglobin, over time, if there's a lot of sugar in the blood, the sugar gloms onto the hemoglobin. Okay, and so what's beautiful about a hemoglobin A1C measurement, as opposed to, say, a random glucose or a fasting glucose, which is a snapshot, this gives you a ton, like what's been happening over the past several months. And the reason that is because hemoglobin A1C is measuring how much sugar has glommed onto your red blood cell and your hemoglobin in your red blood cell. Once it's glommed on, it stays glommed on for the life of the red blood cell, which is about 2 to 3 months. So hemoglobin A1C, when you measure it, it gives you a sense of what your sugars have been for the last 2 to 3 months, which is much more useful clinically, I would say, than just what your sugar is at this very second. Because you might be starving and your sugar would be low, or you might have just gone to Dunkin' Donuts and your sugar would be high. This tells me what it's been, and you can't kind of escape that. Like, I know what's been going on for you for the last 2 to 3 months. So this is incredibly useful. That's the hemoglobin A1C. The oral glucose tolerance test, again, this is not something that we do very often. If it is used clinically by anyone other than endocrinologists, it's actually used most commonly by OBs, because this is how usually we diagnose gestational diabetes in pregnant women. We do an oral glucose tolerance test, okay? And so what happens is, and I don't know if anyone's ever had one before, I've done it during pregnancy, it tastes disgusting. So it's this like orange, usually orange gunk that's pure sugar. 75 to 100 gram load of sugar. And the purpose is, so you don't eat or drink anything for 8 or 10 hours. Then you take this huge load of sugar, and then they keep you in the lab and they test your blood at 30 minutes, 1 hour, but it's really at about 2 hours. So you'll see oftentimes in your labs and your variables, you see a 2-hour glucose tolerance test, 2-hour oral glucose challenge test. This is all the same thing. At 2 hours, they'll test your blood and see what your sugar is. If your insulin is working as it should, if you're generating insulin and your body's using it appropriately, your sugar will come down, your glucose will come down at 2 hours. If it's not being used appropriately or it's not being made appropriately, your sugar level will be high. And we say if it's above 200, you have diabetes. Okay? So that's what that is. Okay, how do we treat obesity, not just obesity, how do we treat diabetes in the clinic? Main things are, so there's pharmacologic and non-pharmacologic. We always start with non-pharmacologic if we can, if it's not too severe. Non-pharmacologic, the main things are diet, exercise, and weight loss. Those are by far the biggest things, which are also, by the way, the hardest to do and the hardest for, as you may all know, the hardest to accomplish. So dealing with obesity can actually prevent diabetes from progressing if it hasn't progressed, or it can improve how your diabetes is doing. And again, just to remind ourselves how we define obesity, if we define it with the body mass index, which is your weight in kilograms over your height in meters squared. And we say that you're overweight if your BMI is between 25 and up to 30, and above 30 you're obese, morbidly obese if your BMI is above 40. So I would say so at Duke, let's see. So at Duke, in the Duke primary care population, so we just got some data. In the Duke primary care population, 75 to 80% of the population is overweight or obese. And as I recall, and you can correct me if I'm wrong, about like 10% of them, or not quite 10% of them, have a BMI greater than or equal to 40? Somewhere around like something like that, around a BMI greater than or equal to 40, which is a lot of people that we see. If you think about that, that is a lot of people. And so a BMI of around 40 would be, just to give you a sense, would be 2 of me, would be somebody who's about 5'6" and about 250 pounds, okay? The largest BMI I've ever seen clinically, I was in residency where all bad things happen. Young people tell you stories about residency. I was in the intensive care unit, and a woman came in and her BMI was, I want to say 84. So she was like 4'11" and I can't remember exactly, like 650 pounds or something like that. So that just gives you a sense of BMI if you're not that familiar with the measure. And the goal is not, and I think people have a lot of misconceptions about this, If you come into the doctor and you say, how much weight should I lose? Your goal is not to look like Heidi Klum or something at the end of it. We're not trying to get people down to a BMI of less than 25. First of all, that's unrealistic for the majority of people. Second of all, it's not actually necessary. If you, as a diabetic, can get your weight down 5 to 10% of wherever you start, you actually will see improvements in your sugar, you will see improvements in your lipids, you will see improvements in your blood pressure, and if you can maintain that weight loss or improve upon it, those benefits will continue. So the goal is to get you to 5 to 10% reduction and to maintain it, at least. If we can get more off you, great, you'll do even better, okay? In terms of exercise, so the American Heart Association, the American Diabetes Association, this is not just for diabetes, this is what the AHA recommends in general, but that top row is what you would recommend in general for somebody with diabetes, which would be at least 30 minutes, 5 times a week of moderate level, moderate intensity exercise. And so what is moderate intensity exercise? People ask that all the time. That's a really common question, right? Like, what kind of exercise am I supposed to be doing? This just gives you some examples, okay? So moderate intensity exercise would be like you're walking briskly, but you're not like doing your race walking thing. Your water aerobics, biking, not too fast, playing doubles tennis, not singles tennis, ballroom dancing, and even general gardening, which most people don't even realize. Now, if you can do more than general gardening, that's great. But this is what you consider to be moderate intensity. And the other way I tell patients is if you can sing comfortably while exercising, you're not doing enough. But you should be able to talk while you're doing moderate intensity exercise. If you can't talk, you're getting to vigorous intensity exercise. Okay? So you should be able to talk but not sing if you're doing moderate intensity exercise, which is generally what we recommend for folks. But if you want to do vigorous, go for it. These are some examples of vigorous intensity. So swimming laps, singles tennis, aerobics dancing, jumping rope, great exercise, heavy hoeing, hiking uphill with a heavy backpack, things like that. Okay, but this is just to give you a sense that if you didn't know from personal experience, this is a lot harder than it sounds. It sounds like, 30 minutes, like that's not that big a deal and it should be really easy, but it turns out that it's not always that easy. So this is just an experience of one patient who, and you're gonna turn it louder for me, an experience of one patient and what she dealt with, and I'll tell you that this is, I'll tell you that this is, what she says about her diabetes is extremely common.
We are doing a frittata this morning with some asparagus and onions and tomatoes out of the garden.
It took Marcy Stone almost 30 years to learn how to live with diabetes.
This will be my piece because it's tiny since my blood sugar's high.
Skipping her morning toast is no big deal these days. There are more important things to look forward to.
My son's getting ready to get married in October to a woman who has 3 children. Da-da-da, I'm a grandmother all of a sudden. Yeah, things have changed.
Where diabetes is concerned, though, lifestyle changes did not come easily.
I was in complete and utter denial. Denial so strong that
So common.
you don't want to acknowledge that you're going to have to change your lifestyle. And that you can't have the Pepsi that everybody's having, or you can't have the bread that everybody's having.
But Marcy Stone admits she should have known better.
I've always managed to be surrounded by diabetics by one way or another, be it family, be it friends. So how I could be in denial for so long is something I'm having to catch up with now.
That is incredibly common. The people, it's not that easy, is what we find. So even though we can talk about it and make it sound like, all you have to do is change your diet and lose some weight and do some exercise and check your blood sugars and da-da-da-da-da. Actually, what happens to patients is it can feel totally overwhelming, like an avalanche, and most people don't have a really hard time dealing with it, I would say. Okay, so how do we treat it other than telling people to live more healthfully? So I'm not going to go into a ton of detail. We obviously have a lot of medications that we use to treat diabetes. I'll just mention a couple of points. One is that we use metformin a lot. And I'm sure you've seen metformin, seen it in your analyses, know about it from real life. Metformin is often our go-to. That's the thing that if people, they come to you and they're newly diabetic, or even if they're pre-diabetic, you might consider putting them on metformin therapy. Metformin's beautiful for multiple reasons. One, it's really easy, it's oral, has very few side effects. It does not cause hypoglycemia. So that's what you worry about, right? You don't want people to get very low blood sugars. What happens if you get a super low blood sugar? I am going to wait because I want y'all to talk some. You can die, yeah, so you get coma. So like the worst case scenario is that you can die. You feel bad, you feel nauseous, whatever. But people do go into diabetic comas. I've treated multiple patients, again, in residency, who would come in unconscious, in comas, 20 years old. If you don't get them quickly, and this more happens with type 1 diabetics, but if they've taken too much insulin or whatever, but can happen with type 2 diabetics on medications as well. If you don't get to them quickly, they can die. So the beautiful thing about metformin is you don't get that. It never gets your blood sugar too low. Plus, you lose weight. It causes you to lose weight. Plus, up until very recently, it was the only diabetes medication that had a positive signal for cardiovascular disease outcomes. So up until recently, the only medication that we had that would improve cardiovascular disease outcomes was metformin. So that's the gold, right? You start with that. But for most people, well, not for most, for a lot of people, that's not enough. It won't get your sugar down to where it needs to be, okay? And for those people, there are a range of other medications that you could try, but one thing that many people will end up needing at some point or another, whether even if they're type 2 diabetic, is insulin, okay? And insulin is just giving you back the hormone that isn't working. Can be difficult, especially if the issue is not just that you're not making enough insulin, but you're not responding to it. Then you need to start overwhelming the system with insulin. So you need to start giving people lots of insulin. As you can imagine, that can have side effects and also can cause hypoglycemia, which can be dangerous as well. So all of these this is why people need to monitor their sugars so carefully. But between metformin and insulin, there are like a bajillion other medications on the market, like a billion of them, and they have their own profiles, their own side effects. Some of them are great, are okay, some of them are not so great. I'm not going to go through all of them, but just to say that, like I said, until what I'm about to talk about now, none of these other medications could move the needle on cardiovascular disease. So even though we were able to improve A1Cs and then the level of dysglycemia in people, dysglycemia, their sugar being out of whack, we weren't able to prevent the subsequent cardiovascular disease. So when somebody became diabetic, just by controlling their sugars, we weren't able to necessarily prevent their heart attack or their stroke. It's hard to understand why that is. We have been able with the other medications and insulin and so forth to prevent microvascular disease. Again, why we think of these in buckets. Microvascular disease improves, so less amputations, less renal disease leading to dialysis, less blindness, improves with insulin and getting your A1C down, but cardiovascular disease did not until very recently. And this is what's been really exciting. You may be hearing about some of this. You may have heard of the Excel trial, which we did. So I'll talk very briefly about these. In 2008, the FDA, in all its, it's frankly, and it's wisdom that, this is before Caliph went, so I can say this. They didn't realize how good it was going to be. Basically, they decided that they had seen some safety signals in other oral diabetic medications that were concerning to them. Specifically, sulfonylureas looked like there was an increased risk of MI and cardiovascular death, and TZDs also looked like they had an increased risk of heart failure. So based on all of that, they said, you know what? If you want to bring your diabetes medication to market and you want approval from the FDA, you're going to need to prove in a phase 3 or phase 4 trial that compared to usual care, you do not, your effect on cardiovascular outcomes is non-inferior. So they mandated a non-inferiority trial for all diabetes drugs that wanted to come to market, which ended up being a huge issue because this is incredibly expensive. And do you really need to do that? And not just for a class of drugs, but for each individual drug, right? So everybody thought this was a huge waste of time, and then EMPA-REG Outcomes came out. EMPA-REG Outcomes was a trial, not done by us, with this medication called empagliflozin, Jardiance. It's an SGLT2 inhibitor. Basically what it does is it inhibits the near part of the kidney nephron, and so it stops you from reabsorbing any sugar in your urine, so you pee out sweet pee. Okay, and so that's how you can think of an SGLT2 inhibitor. You're peeing out You're peeing out sugar. And so it gets your sugar down. And when they did this trial, they did it for they powered it for non-inferiority, and it came out in 2013, 2015 maybe. And it showed superiority. It showed improvement in cardiovascular outcomes and improvement in all-cause mortality, and people were shocked. And then Victoza, a totally different medication called liraglutide, it's a GLP-1 agonist. GLP-1 agonists function in a totally different way. The GLP-1 is actually a receptor in the intestine that leads to increased insulin secretion. Again, something totally different. They tested it, also superior, also improved cardiovascular outcomes, also improved mortality. And it was, I mean, this has been like the big thing in diabetes and cardiovascular medicine. So and then Bidurion is Excel, is what we just tested in Excel, which you may know just database locked and it's not come out yet, but I'll go through some of this. So this is a lot of information. I'm not going to go through all this, but this gives you, maybe this is, you're waiting for this because you've seen all this like clinical stuff and you're waiting for numbers. And so these are some numbers. So EMPA-REG outcome leader, which tested liraglutide, and SUSTAIN 6, which tested semaglutide, similar to liraglutide, but a different drug, probably a little less potent and a different manufacturer. These are the 3 trials that came out in the last 3 years that have kind of like rocked the diabetes and cardiovascular world. And so I'll just mention briefly. So for empagliflozin, again, that's the sweet pea one. Yeah. Tested again, excellent question. They were tested against usual care. So the clinician could use whatever they wanted except for open label, that drug open label, or something else in that class. And the idea was to get it, and you guys know Rory Holman. So he, from DTU, he ran TICOS and Excel with us. And he talks about the, what does he say? The glycemic equipoise. You need to have glycemic equipoise. So you want to know if the outcome that you're seeing is because you've done something to the A1C, or all things being equal, you lowered the A1C just as much and you controlled the sugar part of the diabetes just as much as your control. Do you still see it? Is it doing something else? Are you still seeing an improvement in cardiovascular outcomes? And so that's what these are seeing. So you'll end up seeing that they lower A1C just as much. These people had to get to target regardless. So all of the people in the control arm and in the intervention arms got to about the same degree of A1C lowering, but you ended up seeing with the study drug, you ended up seeing more improvement in cardiovascular outcomes. So for empagliflozin, they only looked at a secondary prevention population. They only looked at people who had diabetes and known cardiovascular disease. They followed people for about 3 years, and oh yeah, here we go. And they reduced MACE events by 14%. And cardiovascular death by 38%. And we've not seen numbers like this in the diabetes space ever. This is much more than metformin. And it couldn't quite be explained by MI or stroke. These were non-significant. If anything, stroke was going the wrong direction. But amazingly, there was a heart failure signal, which nobody could fully understand. Like, why is this improving heart failure hospitalization by 35%? And people don't really know. And when you look at the trial, it didn't kind of assess heart failure outcomes as rigorously as a heart failure trial would have. And so it's being retested now. I think the trials are called Emperor and Emperor-R or something like that. And they're looking at heart failure with empagliflozin as well, just to see if this signal was real. But you now start to see, benefit that we've never been able to show in diabetes before. And the adverse effects you tend to get, there tended to be some pelvic infections. So something to watch out for, but people didn't die from it. And the thought was here, when you actually looked at the curves for heart failure, the curves spread early. The thought was that had to do with some kind of hemodynamic effect. Like you were changing the dynamics of the fluid in the body, and that's what happened early. So people are starting to wonder, well, do people with diabetes actually have this kind of unrecognized volume expansion? Like they're not really in heart failure, but they have more volume on board. It's causing their blood pressure to be a little higher. Their heart is starting to remodel a little bit. Their heart muscle's stretching a little bit. Maybe it's predisposing them to arrhythmias, which can lead to sudden cardiac death. Do they have this unrecognized volume expansion that we never realized they had, but when we start to basically diurese them, right? Because empagliflozin is making you pee out sweet pea. You're diuresing them. You're getting fluid off. Is that what's improving their outcome? So a lot more is going to be done in this space. Liraglutide was tested in LEADER. They looked at both a primary high-risk population and a secondary prevention population. They also saw an improvement in MACE and where we are. Where do we go? There we are. Oh, it goes away. How weird. Anyway, they also saw an improvement in MACE and cardiovascular death, as you can see here. MI and stroke were non-significant. It all went the right direction, though. They also they did not see an improvement in heart failure hospitalization. The issue with liraglutide, and this will come up with Excel as well, is that you feel horrible, which is part of the reason that they lose weight with this medication. You're nauseous all the time, and so you don't feel like eating, and so you lose weight, which is good, but you feel horrible. But over time, that starts to dissipate, and you start to feel better, but the weight loss generally stays off. Semaglutide, basically, don't want to go through the details, but what's interesting here is that it looked like MACE was even more significantly affected, not by CV death though, but you do see a stroke improvement. And so what it started to make people wonder is there a drug effect, not a class effect? And that's why Excel is going to be really exciting. So Excel, as you know, tested another one of these GLP-1 agonists, exenatide, and the press release just came out a couple of weeks ago. It was non-inferior but didn't reach statistical significance for superiority, and the results will come out at EASD. So again, kind of dealing more with this issue of is it a class effect or a drug effect. Okay, so now to see if you've all been paying attention, to see if you think I did a better job than this idiot who I'm going to show you, and also kind of to summarize things, I'm just going to show you this and you can tell me if this is useful or not.
So let's start with what it is. What is diabetes?
So one of the biggest challenges we run into is folks call it a little bit of sugar, right?
Yeah.
Just to write it off is not so important. I want to be crystal clear on this, so I made an animation.
Okay,
Love that. Let's pretend you put some food in your mouth,
best.
okay? And let's just say it's some tortillas with a little bit of cheese on it. It's pretty benign looking. Goes into your mouth, into the stomach, just freezes for a second. So there's the stomach digesting the food. There's the liver, which has to take all the nutrients to decide what to do with it, including making sugar out of it. Gallbladder's the green stuff, and this organ right here, that yellowish thing, that's the hero today. That's called the pancreas. Let's run this forward.
That's the hero,
food goes
guys.
through the stomach, into the small bowel. The bile, the green stuff, and the yellow stuff from the pancreas, they mix. And there's the pancreas there doing its best to keep up. The food is being washed like you wash soap off.
That's
Some
not
grease.
true.
And the molecules of glucose or sugar get absorbed into the body. Now, let's cut into the bloodstream. The sugar now is traveling around, and these little particles here are insulin. And these insulin particles are being released from the pancreas. And what the pancreas is trying to do, freeze us for a second, is to take the sugar, these blue dots coming in are sugar molecules. And the insulin is saying, come to me, like a funnel. It's allowing the sugar to go past the bloodstream into the tissues. Goes to our brain. Our brain can only use sugar to think. Makes us think better. Goes to our muscles so we can exercise, right? But it does other things too.
Now, is sugar a substitute for the word carbohydrate? Because I know our brain needs carbohydrate to think.
Exactly. Simple carbohydrates are
carb-
sugars.
Okay.
Complex carbohydrates are sugars with some kind of fiber attached to them.
Okay, got
Real
that.
foods.
Got
okay.
that.
Now, what happens, run this forward, if you have too much sugar going in? We store it in our belly. That's how our ancestors survived.
I can't
but
take
that
it anymore.
belly fat,
Anyway,
the omentum,
that's-
gets pondering.
I thought it would be a good review, but it's like more than I can handle. So yeah, so you can tell me if I did any better than Dr. Oz. And so I'm happy to take any questions. I don't know if this was useful or not. Again, I started over at like 4:30 this morning because I was like, I don't think what I'm going to talk about is very useful. Hillary's laughing because she knows. I thought about starting over last night, and it was really this morning where I was like, no, I'm going to start over. So I hope it was useful. I hope it was something you didn't know, or did you all know all of this before? No, Daniel says no at least. Okay. Are there any questions? Can I answer anything?
So what's the future of treatment? So it sounds like we're involved in the Excel.
We did Excel here, yeah.
Okay. Yeah, so what do you see as kind of the next steps?
Yeah.
And in particular, is there anything that you think is going to be helpful for the weight loss, increase exercise, change diet?
Yeah.
Because that's such a challenging component.
Yeah, so excellent questions, all of them. And I would say for the diabetes specific part first, for like the diabetes medications, the things that deal with, lowering your A1C and stuff, the future is in these medications that we're seeing come out now. The terms that you'll hear again are SGLT2 inhibitors, DPP4s, GLP-1 agonists. Those are these new medications that are being tested now, and even other new ones will constantly be coming out because this is a huge market, so there will always be drugs that are tested. But new drugs that are coming out are gonna have to compete with drugs that we now know improve cardiovascular outcomes. And so things have suddenly shifted in a way that's really good for patients, I think. Of course, these are incredibly expensive medications, and we have a suspicion that nobody's using them yet. We're looking at that right now with claims data to see if is anybody actually using these. Some of these trials have been out for several years. A lot of people I expect that we'll see very few people actually on these medications for multiple reasons. Both because they're incredibly expensive and because people don't really know how to use them. Some of these are injectables that people don't necessarily want to do. Some of them feel bad, even though they give you good outcomes. And then a lot of physicians don't know what to do with these. These are new medications. So that's, I think the future of diabetes is not only, I would say, coming up with new drugs, which will clearly be done, but it's figuring out how to get the drugs that we know work to people, because that we're not doing currently very well. For the other part of it, how do we do everything else, and how do we get people to exercise and lose weight and eat more healthfully? And I would posit that no one knows how to do that right now, at least on a population level. There are some doctors that can influence their patients and so forth. Certain things will work. We know Weight Watchers can work for a certain group of people. There are several JAMA papers showing that Weight Watchers was useful. But there is no population level intervention that we know makes people lose weight and keep weight off, makes people exercise and stay exercising, make people start to eat healthfully and keep eating healthfully. And so we're trying all these things right now. We've got a bunch of studies that we're doing. We're in the midst of a bunch of different trials and intervention things and looking at behavioral economics, and we're working with the Dan Ariely group to see how can we influence. We've got Anne-Marie Navarre and I have a worksite intervention with a construction company here. There's 1,200 construction workers who are in need of some cardiovascular and diabetes preventive work. And we're working with the Dan Ariely group to see what kind of behavioral economics things we can put in place. How can we incentivize people to do what we know they should be doing, but it's hard to do, things like that. Yeah, you had a question, yeah.
I did. Does insulin resistance occur in people with type 1 diabetes as well?
So generally, again, maybe if I were an endocrinologist, I could tell you there's some aspect of that where that's the case, but in general, no. In general, the issue with type 1 diabetes is that you are not creating insulin to begin with because your beta cells are dysfunctional, and they're dysfunctional because they've been attacked by your own immune system usually. And so it's not that your muscles and stuff are not responding to the insulin properly. It's that you're not creating it to begin with for type 1. Sure. Do you still have a question? It's gone.
No, I still have it. I'm just not sure. So the liraglutide?
Yeah.
If it causes you to lose weight because it has a bad side effect of being nauseous, could you use it to get things under control and get your weight down, which would control one of your risk factors, and then go on metformin or something that doesn't have side effects?
Yes. So, yes, brilliant. And the company thought of that too. So liraglutide is marketed as Victoza at a half dose for diabetes control, and it is marketed as Saxenda in double dose for weight management. So it can be used as either, and both will work for both. So you'll get more weight loss with the higher dose, Saxenda, or just take a higher dose. Well, liraglutide, you would actually have to get the higher one because it's an injectable, so it's not like you could just increase your dose. But so some people will use that just for weight loss, and it can be used just for weight loss. It can also be used for diabetes as well. What we saw with exenatide, so I manned the hotline, the clinical hotline for 2 years for Excel, and so like when they would call me in the middle of the night from Hungary saying the patient will not take it, the reason usually is because they feel nauseous or they can get bumps and stuff at the site of the injection. The nausea will wear off over time. So, but the satiety will stay somehow. Part of that is because part of what GLP-1 does, the peptide, part of what it does is actually signal to your brain a signal of satiety. So it's probably not just that you feel crappy. That helps in the beginning. But then as that wears off, you still feel full. Plus other things are going on in your gut that GLP-1 agonists do as well.
Use it as like a pre-diabetes, let's get that to go away so that...
So pre-diabetes, fascinating space, that's what my K will be on. Pre-diabetes, so people have not used this specifically for pre-diabetes. The only thing that's been tested in pre-diabetes, so pre-diabetes would be defined as somebody who's not quite at diabetes, right? So your A1C is between, say, 5.6 and 6.5. 4, as opposed to 6.5 or above. And for individuals with prediabetes, you have a 5-fold risk of developing diabetes in any given year versus somebody who has normal sugars, and you have a 20% increased risk of cardiovascular disease. So it matters. For people with prediabetes, the best thing, is that me? Oh, it's my hair, thank you. The best thing is actually a lifestyle intervention. So they tested the diabetes prevention program back in the 80s, and it was this intensive lifestyle modification. It was one-on-one health coaching, really resource intensive, taught people about diet and exercise. People lost weight, and there was like a 30-some% reduction in diabetes incidence over just a few years. And they actually tested that against metformin to see if you gave people with prediabetes metformin, and there was an 11% reduction in diabetes incidence with metformin. And so it's good. It's not as good as doing all the other stuff, but metformin is good. And so some guidelines will actually recommend you treat people with prediabetes with metformin, but it hasn't gotten a clinical indication for that. And there was actually a study that I saw recently that something like less than 2% of the population of prediabetics are treated with metformin. So people aren't treating people with prediabetes, but they should be. We should be, because 1 in 3 people in the US have prediabetes. 1 in 3 people. And so what are we doing with that population? It's a big issue. Good question. Yes?
What percentage of diabetics are recognized as prediabetics before they're actually diagnosed?
Oh! Nobody knows the answer to that, because that would require on a population level, you see the natural history. And so nobody knows the answer. The reality is that everyone was pre-diabetic before they became diabetic.
Right, but acknowledged.
Acknowledged. Oh, I don't know. That's a good question. I guess somebody must know, because we somehow know that a third of the population is pre-diabetic, and we know that about 12 to 14% of the population is diabetic. I mean, I'm sure there's some data set that we could eventually figure that out, but I don't know the answer to that, where it's been recognized and like you could have done something. But there's probably going to be, there's a lot of them. And so at least like for me, I'm really interested in people with prediabetes and in understanding how do we actually, a third of the people, it's all well and good to say we should be doing this high intensity lifestyle modification for 1 in every 3 Americans. That's never going to happen. Like that's just not feasible. And so can we find a higher risk portion of the pre-diabetic population who we should be targeting? And are there other ways other than this diabetes prevention program, like using mobile health stuff, where we could be targeting them? So that's what I'm studying for my K there. Anything else? No. Some minutes to spare. Enjoy your early lunch. Thank you guys very much for having me.
Does everybody have an evaluation sheet, Paul? There's one.